Well, thank you so much for a lovely presentation, Katie. People who've worked with me know I like to take on controversial topics, and if we can, actually bring an evidence basis to the discussion. And I've become very interested in the obesity paradox in older persons in the last 5 or 6 years. In particular, how BMI, body mass index, relates to health and mortality outcomes, especially with a focus on older persons. So we'll jump right into this. We're going to talk a bit about mortality outcomes in relation to BMI, health outcomes, the obesity paradox. Are there benefits to obesity? And of course, you want to create a ruckus, just say that. And most importantly, we're going to talk about a host of confounding variables. So, how does body weight affect health? On the overweight side, it clearly does impact upon the duration of life. It's associated with premature disease and chronic diseases and functional decline, especially mobility limitations. On the flip side, underweight, the Nurses' Health Study actually found the lowest mortality for those weighing 15% below the national average. And of course, the National Institutes on Aging has been very interested in studying dietary energy restriction and metabolic outcomes and ultimately longevity. Early studies looking at BMI and mortality outcomes were very much confounded by smoking and disease burden. So I think it's safe to say, and we'll come back to this at the end, that obesity generally does not confer health benefits. And in general, there's a J-shaped mortality curve in relation to body mass index with elevated mortality at either end of the body mass index spectrum. Obesity is associated with all-cause mortality. Now, very importantly, it is a much stronger predictor at younger ages, young adults, middle-aged adults. And it is associated with decreased life expectancy, and in fact, some recent projections have suggested that because of the current epidemic of obesity in our youth, that they may not ultimately live as long as current adults are projected to. So this is a figure from Pishon in New England Journal of Medicine that really is simply showing that this J-shaped relationship with mortality, males in the top panel, women in the bottom panel, really exists for body mass index, waist circumference, and even waist to hip ratio. And of course, part of all this is that, as this audience is well aware of, that obesity is related to a host of significant comorbidities. I don't want to go through them all, but of course, major players in terms of mortality: diabetes, dyslipidemia, metabolic syndrome, hypertension, things like that. And increasingly, when I first started publishing things about obesity in older people, literally 15 years ago, people just laughed at us. They're like, "What are you talking about? Or there's something weird going on in central Pennsylvania." You know, the historic focus was really all on tiny, frail, older persons. And those of you that work with older people today, whether it's in the communities, skilled nursing facilities, acute care, where have you, know that there are now many very large, frail, older persons. And we're dealing with the entire continuum, everything from very small, frail older people to very large, frail older people. And that's true in the intensive care units and skilled nursing facilities in the community. And of course, it's associated, weight excess in older people, with profound functional decline. And at the higher end, we've published work from our cohort studies showing that it is a risk factor for becoming homebound. Limited mobility function is profound among very large older people, as you can imagine. Well, there have been a bunch of interesting papers looking at the relationship between BMI and outcomes in older persons. This one here is from Kathy Flegel, 2007 in JAMA, looking at the cause-specific excess deaths in different BMI classes using NHANES data very large database. And perhaps not surprisingly, but you can see here on the upper end, more of the deaths were associated with cardiovascular disease, and cancer is considered to be obesity related. If you go down to the very lower end, then more non-cancer, non-cardiovascular deaths, things like end-stage COPD, things like that. And this is just some data from this paper showing the same thing. So if you look at coronary artery disease here, at a BMI higher than 30, marked increased risk of death associated with coronary disease. And then also, if you look at cancers considered to be obesity related, at the higher range of BMI, as one might anticipate a relationship there. So the disorders associated with mortality vary by BMI. Well, there we go. This is another very interesting study from Sue in JAMA 2007, 2,000 plus older adults who underwent exercise tolerance testing on a treadmill, BMI, body composition, and outcome was 12-year follow-up, all-cause mortality. Now in this range, these would be, many of these are young older people, if you will, as opposed to old older people. Anyway, the key finding was that fitness was a significant mortality predictor independent of adiposity. And I've got some of their data right here. So this is divided into fit and unfit. Here's BMI, waist circumference, percent body fat. But just take a look here. Let's go out, where's my pointer here? Go out here, so we're in the mildly obese or severely obese categories, and compare the odds ratios here for the unfit versus fit in relation to mortality. So really dramatic mortality benefits to being fit, and of course this is also likely to relate to underlying chronic diseases and also body composition, and in particular lean body mass. Very interesting study here from Wildman in 2008, and again another big NHANES analysis using the NIH cut points. And what they did was categorize individuals according to their metabolic risk. So hypertension, lipids, fasting glucose, C-reactive protein. And what was fascinating about this, it's not a mortality outcome study, but they basically found that half of the overweight and 1/3 of the obese were metabolically healthy. And then the flip side of that, of the so-called desirable BMI, 18.5 to 24.9, almost 1/4 of them were metabolically at risk, unhealthy. So it's not all or nothing, right? So you can be overweight or mildly obese and metabolically healthy. You can be desirable weight and be metabolically unhealthy. And that's very important. This is just showing some of this data. Top panel men, bottom panel women. Metabolically abnormal are the black bars, and you can see that the numbers are not trivial at all. So it's not one size fits all. So out of all this comes the obesity paradox in older persons. Very nice review article cited here, that in older persons, overweight and class 1, mild obesity, may be associated with lower, not higher, all-cause mortality risk. And of course, this tends to get people all bent out of shape. And a lot of interesting work has come out. This is a relatively small study here in AJCN in 2009, looking at hospitalized older persons. All of them had DEXA and BIA for body composition. And in this analysis, it turned out that fat mass was associated with reduced mortality and complications, while there was actually no relationship with lean mass or appendicular mass, which is just the lean mass in your extremities. And of course, there's been a whole variety of studies like this coming out, some suggesting fat mass, some suggesting lean mass, some suggesting both. And big meta-analysis from Kathy Flegel, published in JAMA in 2013, triggered profound controversy. And it was a systematic review and meta-analysis, 97 studies, nearly 3 million individuals, 270,000 deaths. And compared to the desirable BMI category, 18.5 to 24.9, being severely obese was not good. Pretty much across the board, had a significantly higher all-cause mortality, so classes 2 and 3, so greater than 35. Whereas class 1 obesity, 30 to 34.9, okay, was not associated with any higher risk, and overweight actually had the lowest mortality. Okay, you'd think it would be a message a lot of people would want to hear, but perhaps not. This is some of Kathy's meta-analysis data here. And I should add, in the back of your briefing booklet, these slides are actually there that you can take a peek at. But if you look at the older age group here, so this is 65 or older, both measured and self-reported BMI. If you look at the overweight column here, you can see a significant reduction in mortality risk. Class 1, certainly no greater risk, and it's not until you get out into the class 2, class 3 obesity that you begin to see increased risk of adverse mortality outcomes. So what this looks like, very nicely depicted in this figure here from David Allison's group, is that the lowest mortality for older persons keeps shifting towards higher BMI, as you can see here. So the lowest mortality appears not to be in the realm of desirable BMI range per the NIH. This is some of our work from one of my doctoral students, Dara Ford, published just this past year in a big Pennsylvania cohort. Very similar findings, which we've since extended to longer follow-up and more participants. But what you can see here again is the overweight BMI here associated with decreased risk of mortality, with the reference range being 18.5 to 24.9. So there's just a host of studies that have shown this. And of course, among the concerns that have come out, among practitioners and the public is, well, goodness, even if this is real, we don't want anyone to know about it because everyone will run out and start eating excessively and not moving. I don't think that's true, but a very important part of this is obviously how do we communicate this message to the public and to practitioners. Very important. So one of the key factors in all this appears to be body composition. And sarcopenic obesity or sarcopenic overweight is reduced muscle mass in overweight or obese individuals. This happens to be from a study of older women who were scheduled for knee replacement surgery who are very high risk for sarcopenic obesity. And what you can see is decreased muscle mass. These are thigh cross sections and increased fat mass. Now, that's important because it appears that overweight or mild obesity may only be protective in patients with intact lean body mass. Okay, and of course, remember, reduced lean body mass is likely going to be a proxy for chronic disease, smoldering inflammation, relative immobility. So in fact, you are, when you look at reduced lean body mass, you're looking at much more than just reduced lean body mass. It's a proxy for other things. So it's a very nice study from Tammy Harris's group at NIA, older persons, all of whom had thigh muscle by CT scan, and the highest mortality was in those with low muscle mass, whether they were normal or overweight, all right? And normal weight participants actually had elevated mortality risk compared to overweight, but this paradox was slightly mediated by muscle mass. Makes sense. Now, the obesity paradox itself has generated all sorts of controversy and extends beyond older persons, which is my primary focus. So all sorts of benefits have been reported, reduced osteoporosis, better survival in heart failure, better survival from myocardial infarctions, peripheral vascular disease surgery, non-bariatric general surgery. One of the most curious that I saw was actually reduced suicide risk, which seems somewhat paradoxical since often very obese persons suffer depression, distorted body image issues, all sorts of things. Reality is most of these medical conditions, when you adequately control for other confounders like disease, burden, smoking, things like that, any supposed obesity paradox or advantages of being obese disappears. But nonetheless, these are all examples of health benefits that have been reported in the literature. But the one that is clearly sticking around is older persons. So in thinking more about this, a host of confounders that must be considered. One is, are you talking about individuals or population? Two, how are you measuring composition, body composition? What are you measuring? Certainly, age is very much an issue. And so, we have data to suggest, and I'm sure others do as well, in terms of mortality outcomes. There's a big difference between young older persons and old older persons. Gender, there are also differences. Race and ethnic group, largely unexplored, a wide open area. A disease burden is a major factor I'll come back to in a moment. Smoking, clearly, body composition I've measured, and goodness knows what else we may not yet have considered. So this is my last slide. I think in general, it's clearly safe to say that obesity does not confer mortality or health benefits. But current use of the NIH BMI guidelines warrant re-evaluation for older persons. And we actually are working on a proposal for a workshop next year that I'm working with the Food and Nutrition Board and New York Academy of Science to explore this further. And I certainly would welcome, grab me during a break, I'd welcome suggestions or thoughts on that. We're very interested in looking not just at BMI and mortality, but BMI and function, BMI and body composition, BMI and health outcomes, quality of life. So I think it's a very important workshop proposal. And really, it may be a matter of how we use the current BMI guidelines for older persons. So as an example, I can tell you it is not at all unusual in skilled nursing facilities for folks to tell overweight older persons that they need to lose weight and be counseled to lose 20 pounds over the next 3 months, when for a substantial portion of those people, that is the last thing on earth you should be telling them. So, in terms of research priorities, disease burden is likely a very key factor. And we have data that we literally have just submitted in abstract form, so I cannot share it with you, but I will tell you that one of the key drivers of the obesity paradox in older persons is a substantial number of them who do not have metabolic risk or metabolic disease. And these are the people who will outlive all of us. And as you get older, that is not a trivial number of people at all. It's perhaps as many as a third of people of advanced age. So they're already survivors, and the last thing you'd want to be telling them is lose weight. Okay? Now, I'm not saying anything about class 2 or 3 obesity, right? Nor am I telling middle-aged people run out and eat everything in sight. Okay? That's not what we're saying. So anyway, disease burden. Key issue, warrants further investigation. All right. Body composition, likely a key factor, clearly interrelated with disease burden. And in fact, I would hypothesize that when we look at metabolically healthy people of advanced age, they are likely to be the ones with intact lean body mass. And indeed, elevated BMI may have no protective effect at all in the presence of reduced muscle mass, sarcopenic overweight or sarcopenic obesity. So it's all starting to come together, and we're on the verge of better understanding this paradox in older persons. Another key priority, and certainly for our future proposed workshop, but in this entire field, very importantly, again, is how do we best interpret these findings for health professionals and for the public so that we don't confuse them with mixed messages. And I thank you for your attention.